Thanks for your interest in our study called A Recurrent Machine Learning Model Predicts Intracranial Hypertension in Neurointensive Care Patients, which was published in Brain. Patients that were included in this study were treated on our neurointensive care unit in the last 12 years and underwent intracranial pressure monitoring. The same patients were also included from external and publicly available ICU datasets like MIMIC and eICU. The most frequent ICU information like vital signs with all information about ventilation included, laboratory values, medications and blood gas values were aligned to the external databases. A minimal pre-processing was done to introduce the least bias into the ICU real-world data. An hour was defined as critical when the ICP once rose above 21 mm Hg. Long critical phases were defined as more than 2 hours of sustained ICP elevation. Short critical phases were defined upon 2 consecutive critical hours. 80% of our local data was used for training of a recurrent neural network. Validation took place on 20% of the local data and on all external datasets. To visualize the threshold independent performance of a machine learning model, an area under the receiver operator curve can be used. The higher the AUC, the better the discrimination between true positive and false positive values. It was possible to predict critical long phases upon 24 hours in advance with an AUC of 0.825 with increasing performance upon approaching further to the target. To analyze the machine learning model more in detail, a 2-hour distance to the target was defined as clinically most practical. The AUC of the recurrent neural network to predict long critical phases 2 hours in advance was 0.94 in our independent test set, and the transfer to the external datasets was stable with 0.93 AUC on the MIMIC database and 0.88 AUC on the eICU database. The prediction of short critical phases was more difficult with an AUC of 0.72 in our test set. This was due to the more difficult task and labeling an hour as critical when the ICP only once rose above 21 mm Hg in 1 hour. To analyze the performance more in detail in certain subgroups, we took the area under the precision recall curve. The higher the area under the curve, the better the threshold independent trade-off between recall, which is the sensitivity, and the precision, which is the positive predictive value. This metric is better to show the performance to predict lesser occurrent targets. Focusing on the outcome of the patients, the model predicts much better when patients die on their ICU stay. According to the diagnosis, the model performed quite stable but performed slightly better in the group of patients with traumatic brain injury. Missing data was not as important as we thought, but less missing data enhances the performance. Looking on the ICU time course and the influence on model performance, the best predictions were made in the first week, giving the conclusion that the model performed the best in the first week of ICU stay, independent of missing data and underlying diagnosis. A big research focus was put into interpretability of the underlying recurrent neural networks. Interpretability will play a crucial role when it comes to acceptance of future clinical applied machine learning. To get an overview of the top features influencing the prediction of long and short critical phases, the underlying test set and the 2 external databases were used to analyze feature importance. The past time course of the ICP was the most important feature to predict long and short critical phases in the future. Besides the ICP, the mean arterial pressure, bicarbonate and thrombocytes had a positive predictive value for long critical phases. Machine learning can handle individual patient time courses differently, depending on their multitude of individual input features. This is a big advantage towards standard clinical care when scores or small, simpler statistical models based on fewer inputs are used. An example is given in our paper. The proposed model will play a crucial role in the improvement of future treatment of patients admitted to neuro-ICU, undergoing invasive ICP monitoring. For future updates in this research field, you can follow and contact me on Twitter or per mail.